In the previous section, we have seen one of the major iron deficiency, major microcytic anemia, that is iron deficiency anemia. But in this particular section, we are going to see some of the other types of microcytic anemias. Two of the most important thing: one is the anemia of chronic disease, and second is the sideroblastic anemia. So let us first move on to anemia of chronic disease. So what do you mean by anemia of chronic disease? AOCD. Otherwise, you can also call it as anemia of chronic inflammation. Also, both actually tells you the same thing. So the problem with anemia of chronic disease is something called inflammation, which is typically chronic. The chronic inflammation is the key, which tends to be chronic. So if you ask me, what is the epidemiology in that sake? Anemia of chronic disease is the second most common cause of anemia in the world. So then what is the most common cause? As I already mentioned, iron deficiency anemia tends to be the most common cause of anemia in the world, but anemia of chronic disease tends to be the second most common cause of anemia in the world. So what is the pathophysiology? We have discussed in great detail about the pathophysiology, but people who have not watched the previous videos may be finding this helpful. What could be the pathophysiology? The pathophysiology of anemia of chronic is very simple. It's due to inflammation and excessive hepcidin release. That's the main reason. So if you ask me, the first thing, there's going to be increased cytokine release in any inflammation for that matter, especially the acute phase reactants is what I'm talking about. Cytokines per se, some of the cytokines are acute phase reactants. So in this case, increased cytokines and acute phase reactants means you're going to increase the interleukin 6 and TNF alpha. We've already seen a clear mechanism that these cytokines, with special regards to the interleukin 6, is definitely going to increase the hepcidin release. The moment you increase the hepcidin release, you do two things. One is you reduce the iron absorption in the GIT. You're going to reduce the iron absorption in the GIT. At the same time, you're going to decrease the iron release from the reticular endothelial system. Your RES macrophages can't release iron because hepcidin is going to block the ferroportin. Hepcidin is going to block the ferroportin. That is the reason why you're not going to absorb the iron from the GIT, because this is the portal for iron entry into the bloodstream, either through absorption externally or release from the stores internally from the body. For iron to enter into the blood, you have only a single portal, that is ferroportin. Since hepcidin blocks this ferroportin, you are definitely iron absorption from the GIT as well as iron release from the reticular endothelial system is definitely going to be reduced. There is no doubt about it. So since the iron absorption from the GIT is reduced, definitely the patient is going to have something called a low serum absorption of iron. So low serum iron. So since your iron release from the RES is also reduced, this is also definitely going to release in something called low serum iron. So this low serum iron is a characteristic finding, number one. At the same time, since the patient is having low serum iron, if you see, the transferrin saturation also will be low. The TSAT also will be decreased in these patients. Again, the main reason is because when you have a low iron in the serum, obviously this is what is going to cause the transferrin saturation, which we have discussed in detail in the last. So in the transferrin, if you take the amount of serum iron is what is going to contribute in transferrin terms, if you talk, that is what we're going to call it as transferrin saturation in the first place. So TSAT is also going to be reduced. And you think this is somewhat similar to your iron deficiency anemia. For example, other parameters that might correlate with your iron deficiency anemia is the patient might have low hemoglobin, that is because of the low serum iron. At the same time, patient will be having low RBC count as well as the low reticulocyte count, because here the iron is unavailable for the RBCs. Iron is not available for the RBCs to synthesize hemoglobin. Typically you ask me here what is happening, it's not a true iron deficiency. Patient may be taking adequate amounts of iron, but this is something called a functional iron deficiency. This is what we refer to as something called a functional iron deficiency. The reason is because iron is available orally as well as iron is available in the stores, but it is not released into the circulation, and because of that the erythroid precursors cannot use this iron. So that is the reason. So reduce RBC count, reduce reticulocyte count, all these things are absolutely very matching with your iron deficiency anemia. At the same time, your anemia is going to be microcytic and hypochromic, which I can write it as something called a MCHC. This is a microcytic hypochromic anemia, and again which is very correlating with features of iron deficiency anemia. So these are the general features that match with iron deficiency, but what are things that stand out and tell you that it is not an iron deficiency, that is likely to be a anemia of chronic disease? The most important thing is the serum ferritin levels. You know the iron release is reduced from the reticuloendothelial system, so definitely you know very well your serum ferritin is going to be increased, or sometimes even it can be normal. So serum ferritin will be normal or increased. So whenever you have a feature of normal serum ferritin, when you have features of iron deficiency anemia like low hemoglobin, microcytic hyperchromic anemia with the low transferrin saturation and low serum iron, but you see a normal serum ferritin or a high serum ferritin, always think about anemia of chronic disease. Maybe it is a simple anemia of chronic disease, or it might be even like an iron deficiency anemia that is combining, but that is having a mixed feature of anemia of chronic disease. So both may coexist with each other. You have to think about that possibility also. So whenever the most important clue is that the serum ferritin is normal or increased. The reason why serum ferritin is normal or increased is because in this condition iron stores so generally tends to be normal or even increased. At the same time, your ferritin itself is an acute phase reactant. It's a positive acute phase reactant. Because of that, your ferritin levels may be increased in acute inflammation or a chronic inflammation. That is the reason, because it's an acute phase reactant. That is the reason why your ferritin may be normal or even increased in this condition. Since the stores are normal or increased, so if you ask me, if you correlate with another thing, since the stores are normal or increased, if you ask me intracellular iron, we have seen the hypothesis, we have seen the iron response elements and the iron regulatory protein model, where the intracellular iron decides the transcription of, the translation of certain mRNAs. How the iron regulatory proteins bind to the iron response element, whether the 5' end or the 3' end, we have already discussed in the previous videos enough. So right now what I'm trying to tell is, whenever the stores of iron are very high, which means the iron availability within the cell is very high, definitely your translation of certain mRNAs is going to be decreased and translation of certain mRNAs is going to be increased. For example, since the stores are normal or increased, your transferrin receptor transferrin receptor mRNA translation is going to be definitely decreased, which means the amount of transferrin receptor is going to be surely decreased. There is no doubt about that. So since the transferrin receptor is decreased, synthesis is decreased, your soluble transferrin receptor definitely will be low. At the same time, if you ask me one more thing, what will happen to your transferrin levels? Your serum transferrin levels also will be decreased. Since the serum transferrin level is decreased, because of that, your total iron binding capacity also will be decreased, because you know very well your total iron binding capacity depends on the transferrin, because it is just equal to the transferrin. Your total iron binding capacity is equal to the total serum transferrin levels. You know very well, we have already discussed this enough. So these are the things that are going to be of paramount importance. So if you again correlate one more thing, if you take and see one more ratio, that is called soluble transferrin receptor divided by log of ferritin ratio, you know what is going to happen for sure. So which means here the soluble transferrin receptor is decreased, but the serum ferritin is normal or even increased. So since the soluble transferrin receptor numerator is decreasing and the denominator is normal or even increasing, the ratio tends to be less than 1. So very, very important. We already seen in iron deficiency, the ratio tends to be more than 2. But in this case of anemia of chronic disease, the ratio tends to be less than 1, which is a very, very, very important finding. So these are the things that differentiate, that stand out from iron deficiency anemia, like your ferritin normal or increased, definitely that's a standout finding. Then you have your transferrin receptor that is decreased, a standout finding. Actually, this is increased in iron deficiency anemia. Your soluble transferrin receptor is decreased here, which is again a standout finding, which is increased in iron deficiency. Again, serum transferrin is decreased, again, which is increased in iron deficiency, decreased in anemia of chronic disease. Your TABC is decreased. Again, this is standard finding, because in iron deficiency, your TABC is going to be increased. And again, the serum, soluble transferrin receptor to log of ferritin ratio will be less than 1 in case of an anemia of chronic disease, and it's going to be more than 2 in case of less than 1 in anemia of chronic disease and more than 2 in case of an iron deficiency. So all these are standard findings. Whatever marked in this pink color in this, All these are standard findings which differentiate your anemia of chronic disease from iron deficiency. So if you want to tell this in a very graphical representation, maybe I can tell you like this. For example, if I am going to draw something, an image like this, like if I tell this is the normal transferrin levels, in the normal transferrin levels, you know, some part of the thing is saturated with iron. So this is the serum iron I'm going to talk about. So the serum iron comes from two sources. One, the serum iron is going to come from the GIT, and second, the serum iron is going to come from the stores. Here the problem is very simple. So let me put the normal thing first. So if you ask me the stores, there are going to be some amount of stores. So let me put this as the stores. This is blue. This is the stores. You know very well, this is the total transferrin. So the total transferrin is the one that is going to give rise to something called a TABC, and that is also going to be something called a serum transferrin, soluble transferrin receptor. Everything you can take it in a similar way. So if you take this is the normal finding, and what will be the graphical representation in an anemia of chronic disease. If you ask me what will happen in anemia of chronic disease, you can draw your stores are going to be very, very high, almost full stores, because the reason is your stores are blocked from releasing the iron into the blood. At the same time, your GIT is also blocked, because like your absorption from the GIT is also blocked. So this also can't pour into the blood, pour iron into the blood, because the stores are increased. So that is the reason why your serum ferritin tends to be normal or increased. Serum ferritin tends to be normal or even increase in this case. At the same time, if you ask me, since this is a sign of storage iron, your intracellular iron is increased, your synthesis of transferrin is going to decrease definitely. So your total iron binding capacity will surely decrease. There is no doubt about that. Your transferrin secretion itself, transferrin synthesis itself is reduced. At the same time, the amount of iron that is reaching the circulation is extremely less. So that is the reason why your serum iron also will be significantly reduced. Your serum iron is going to be significantly reduced. That is the reason why serum iron is the one that is reflecting as the transferrin saturation also. So the transferrin saturation also will be reduced. So you can see a lot of findings: serum iron reduced, transferrin saturation reduced, but ferritin tends to be normal or even increased, and TABC tends to be decreased. So these are the classic hallmark findings to represent in a graphical fashion in a anemia of chronic disease. So I can put here, this is what we call it as anemia of chronic disease. So if you ask me the etiology, next moving on to what could be the etiology, what could be the reasons for getting this anemia of chronic disease, anything to do with the chronic inflammation, anything to do with a chronic inflammation. For example, you can develop autoimmune disorders. Very common reason is an autoimmune disorder. For example, like a rheumatoid arthritis or a SLE, systemic lupus erythematosus. So any chronic inflammatory states. Second thing, malignancies. So a lot of malignancies can predispose. Remember, malignancies can cause true iron deficiency anemia also. Like for example, the malignancies in the GIT, mucosa. Like typical example with a cancer presenting like iron deficiency anemia is a colon cancer. Very important. But a lot of other malignancies, like internal malignancies, internal solid organ tumors like your breast cancer, your lung cancer, or a lymphoma. All these things these are not mucosal cancers. Mucosal cancers tend to bleed. That is the reason why they can come with an iron deficiency. But these cancers generally don't bleed really unless until a lung cancer causing a massive hemoptysis. Apart from that, it is very unlikely to cause an iron deficiency. But instead, they come with an anemia of chronic disease. And number 3, you can get with a chronic infection. Not only inflammation, even with a chronic infection. The classic example in our country is going to be tuberculosis, HIV. All these things. Even HIV, they can cause anemia due to a lot of mechanisms. Even they can cause bone marrow suppression as well. That is different. One of the common hematological findings with HIV is anemia. Even some drugs like zidovudin can cause anemia in HIV due to bone marrow suppression. HIV itself can cause bone marrow suppression. At the same time, HIV also can cause anemia of chronic disease. So a lot of things are there. So these are some of the few etiologies for your anemia of chronic disease and inflammation, anemia of chronic disease and inflammation. So next thing, I told you the investigations and diagnosis already, so there is nothing to worry about that. If you ask me the investigations, I'm going to see the RBC indices first. So the moment I see the RBC indices, your hemoglobin is decreased, MCV is decreased, but remember MCV can be normal in early stages. MCV can be completely normal in early stages. If you take the peripheral smear, it is going to show microcytic hypochromic picture. This is classical, but it can be normocytic normochromic in early stages. You have to know about that also. In early stages, it can be completely normocytic anemia also. Peripheral smear, then your RBC count will be reduced, your reticulocyte count will be reduced, because this is also one of the hyperproliferative anemias because of poor availability of iron. It's a functional iron deficiency. So again, this will be a hyperproliferative anemia. One of the important example of hyperproliferative anemia is not only iron deficiency but also your anemia of chronic disease. Even sideroblastic anemia for that matters is an example of an hyperproliferative anemia only. So reduced RBC count, then the patient is going to have reduced transferrin saturation. At the same time, they are going to have a reduced soluble transferrin receptor, and the patient is going to have a reduced serum transferrin as well, and the patient is going to have, because of these reasons, the patient is going to have reduced TIBC as well, reduced total iron binding capacity also. So but serum ferritin tends to be normal or increased. So these are the typical RBC and iron findings. So these are the iron indices and these are the RBC indices which I have talked before itself. So if you ask me other non-specific findings, one more specific finding if you ask me, that is I already told you soluble transferrin receptor by log of ferritin ratio, which tends to be less than 1. Okay, this is relatively specific for anemia of chronic disease, but little bit of non-specific finding if you ask me. If there might be increased free erythrocyte protoporphyrin, I told you this free erythrocyte protoporphyrin can be increased in any microcytic anemia except thalassemia. Thalassemia is the only condition where you might have a normal free erythrocyte protoporphyrin, which I have discussed already in the previous videos in detail why it causes that. So all these things we have discussed already. So this is increased is again a very common finding in anemia of chronic disease. So if you ask me the treatment of what you're going to do for this anemia of chronic disease, so first thing is the underlying disease should be treated in the first place. So treatment of the cause, that is what is very important. So once you treat the cause itself, the anemia is going to resolve in majority of the cases. And second thing, if you ask me, your iron can be given, because I already told you many times anemia of chronic disease generally coexists with iron deficiency anemia. Very, very common. This is a common scenario where anemia of chronic disease often coexists with iron deficiency anemia. So why I told you this point specifically is because whenever you have an correlation with iron deficiency anemia, you might expect the serum ferritin to be low, but here the serum ferritin could be completely normal. So normal ferritin does not rule out coexistent iron deficiency. Very important, because ferritin, I already told you, it's a positive acute phase reactant. So a normal ferritin never rules out coexistent iron deficiency anemia along with anemia of chronic disease. That is the reason why many times you might be needing to give iron. Many times you might need to give iron infusions also, but iron replacement therapy is also very important many times. So what is the indication for replacing iron? So indications for replacing iron is whenever the serum ferritin is less than 100 or transferrin saturation is less than 20%, then this finding strongly tells you that the patient is having coexistent iron deficiency, and this is an indication for giving iron replacement also. But what kind of iron you have to give? Typically we use IV iron. The reason is because in anemia of chronic disease your hepcidin levels will be very high, so giving an oral iron doesn't make any sense, because anyway whatever iron you're going to give is not going to get absorbed in the first place. So you have to try and give an IV iron formulation, which is very, very important and crucial in understanding. So you have to give iron replacement if indicated. Then at the same time you can give certain ESAs also, erythroid stimulating agents. Discussion of erythroid stimulating agents is given in detail in the nephrology chapter, where I've told you what are the types of the erythroid stimulating agents you have. But in general, in anemia of chronic disease, what could be the indications for your erythroid stimulating agents. So indications for erythroid stimulating agents is if erythropoietin less than 500. So once your serum erythropoietin levels are less than 500, then you can give erythroid stimulating agents even in anemia of chronic disease also. But one contraindication is there. I mean, one thing you have to know, not absolute contraindication, but one thing you have to know. Suppose if the patient is suffering from a cancer related anemia of chronic disease, in that condition, whether you can give erythropoietin or not, answer is yes. You can still give erythroid stimulating agents. You can still give this EPO analogs, even if the patient is suffering from a malignancy and is having associated anemia of chronic disease. But in one place you should not give in a malignancy is when a patient is having a malignancy but your target for treatment is cure from malignancy. That is, if your patient is having a malignancy and if your goal is cancer cure, goal is curing the cancer, in this condition do not use ASA. But if your goal is palliative, then you can give your erythroid stimulating agents. But if your goal is curative, then please do avoid your erythroid stimulating agents, because there are some studies which showing not so good prognosis with erythroid stimulating agents when your goal is cancer cure, because this is based on the trial test. At the same time, you can imagine like sometimes these are stimulating agents that may stimulate the cancer growth but still unproved, even though only hypothesis theoretically but absolutely unproved. So all these are very important to understand. At the same time, PRBC transfusions are generally avoided in case of anemia of chronic disease because of a lot of reasons, not only this thing. Why you avoid PRBC is because, for example, it doesn't make any sense, because what is only going to produce iron overload, because once the RBs are going to die, again those RBs will be taken up by the reticuloendothelial system. Once they digest these RBCs and rip the RBC into iron and heme components, the iron is not going to be released outside the RES, and you are unnecessarily only increasing the stores, rather than causing any iron homeostasis, improvement in the iron homeostasis. Just the stores will increase by keeping on transfusing. So better to avoid PRBC and try to improve the cause of the anemia of chronic disease. So don't give PRBCs unnecessarily. Maybe you can give PRBC if the patient is acutely symptomatic with a severe anemia. So you have to improve the symptom of the patient very acutely, or if the patient is probably having a heart failure and avoid the complication of severe anemia causing heart failure, you can give a PRBC transfusion. Or if there is insufficient time to wait for your response from your erythropoietin stimulating agents, in this condition, erythroid stimulating agents, in this condition you can give a PRBC transfusion. Apart from that, there is no routine role of PRBCs in anemia of chronic disease. So these are some of the examples. So we have discussed in detail about the anemia of chronic disease. Now we can move on to something called as sideroblastic anemia. So this is another type of a microcytic anemia. So you can move on to something called as sideroblastic anemia. So what do you mean by sideroblastic anemia? Sideroblastic anemia is pathophysiology is due to reduced heme synthesis within the RBC precursors. So whenever there is reduced heme synthesis, I told you already, your hemoglobin comes from two things. One is heme and second thing is globin. So whenever there is reduced heme synthesis, what is going to happen is your hemoglobin is going to be reduced. That is the reason why you are going to get a microcytic anemia. Okay, fine. So when the heme synthesis is actually reduced, the reason for this reduced heme synthesis in a sideroblastic anemia, I told you it is due to not because of iron, because heme comes from iron and protoporphyrin. It's not because of iron, it is because of protoporphyrin. So the blockade is somewhere here. So the blockade is because of reduced protoporphyrin. Because of that only you are having a heme synthesis deficiency. So the iron is going to be increased, which means your iron within the RBC precursors and the RBCs will increase. Actually, this is because of poor utilization of intracellular iron. Remember, your anemia of chronic disease is due to poor utilization of extracellular iron. So you have iron outside, which means outside the cell, outside the GIT, you have intake of iron is good. At the same time, in the reticuloendothelial system, it's good, but intracellular, within the RBC precursor, the iron is very less because there is no iron circulating at all in anemia of chronic disease and iron deficiency. So that is poor utilization of extracellular iron. But here within the RBC precursor itself, we have a lot of iron, but that cannot combine to form heme because of the poor protoporphyrin synthesis. That is the reason why you get an sideroblastic anemia. The important thing about that is this increased intracellular iron. So which means since because of the poor utilization of the intracellular iron, there will be increased intracellular iron. I'm talking about not with the macrophages, within the RBC precursors. So during the erythropoiesis itself, when the RBC precursors take the iron, you have a lot of iron outside in sideroblastic anemia. The RBC precursors take the iron, but within the cell they cannot utilize that iron to produce a heme. That's the reason, because of the poor protoporphyrin. So this increased intracellular iron will accumulate in the bone marrow as something called a ringed sideroblast. So they can accumulate within the bone marrow, or that is accumulate in the bone marrow in the sense that will accumulate within the erythroid precursors. That will accumulate within the bone marrow erythroid precursors to produce something called a ringed sideroblast. This is what we call as ringed sideroblast. This is what is going to cause the sideroblastic anemia in the first place. So where the iron will accumulate intracellularly, intracellular iron within the mitochondria. So they are going to accumulate within the mitochondria. So if you ask me in the RBC precursors, you have an RBC precursor, you have a nucleus here. So which I can put like this, you have a nucleus here, you have the mitochondria here, you have the mitochondria here in the cell. So this mitochondria will show excessive iron, so which what I have put in blue are iron. So they produce something called a ringed sideroblast. So that is due to iron accumulation like a ring within the mitochondria of the erythroid precursor. So this presence of ringed sideroblast is a typical bone marrow finding. So you don't see this ringed sideroblast in the periphery. This is one of the pathophysiologies of the disease, but you don't see that. So this increased iron, so this is not a serum iron, so this is an intracellular iron. This increased iron is not a good thing that is happening to the bone marrow. So this is little bit toxic, going to create free radicals, and they are going to down regulate the erythroid development, and they are going to down regulate the erythroid development, and they are going to reduce the synthesis of the movement of the RBCs from the previous generation to the subsequent generation, which is not possible because they are going to kill the RBC, which will still reduce the lifespan of the RBCs in these patients. So this supposedly this increased iron, this ringed sideroblast in the bone marrow, supposedly somehow they form an RBC. Somehow they form an RBC. Somehow by some reason, not all the RBCs are going to be cut off from the producing a member. Not all erythroid precursors will have this, and not all erythroid precursors not going to produce RBC. So some few erythroid precursors can mature into mature RBC. If they are released, you might see a Pappenheimer body in the peripheral smear. Possible, you might see a Pappenheimer body in a peripheral smear. In a peripheral smear of RBC, you might be able to see something called a Pappenheimer body, which is nothing but within the mature RBC, you can see this iron accumulation within the cell. This is what we refer to as Pappenheimer bodies. Why I am drawing all these things, iron accumulation, the ringed sideroblast and Pappenheimer bodies in blue, is because we are going to stain with something called classically Pearl's Prussian blue stain, which is going to stain the iron. So the ringed sideroblast and the Pappenheimer bodies are best seen with Pearl's Prussian blue. So that is the reason why I am putting all these things in blue color, which you have seen already. So if you ask me the etiology of how your sideroblastic anemia is going to be, so what are the etiologies of sideroblastic anemia? So the number one, the most important, is the ALA synthase enzyme. So because this is the first step, you have something called a succinyl-CoA and a glycine, which unites together to form something called delta ALA, delta aminolevulinic acid. So the key enzyme and the rate limiting enzyme for this step is something called, this is the first step, and this happens in the mitochondria. This happens in the mitochondria. You all know very well this is going to happen in the mitochondria. So this is the rate limiting step in this synthesis, into the heme synthesis. So majority of the problems of sideroblastic anemia will be in the ALA synthase enzyme. So because this step also needs a very important cofactor called pyridoxine. You need B6, you need pyridoxine, which is a very important cofactor. So then you have your delta ALA moving out with the help of ALA dehydratase. You know that you have something called ALA dehydratase enzyme, which is the next step. ALA dehydratase, which is going to cause something called PBG, that's called porphobilinogen. So after that you have a lot of steps which I have discussed in detail in porphyria section. Once again the precursors enter the mitochondria in the final step. So where you form the heme, so you form the protoporphyrin. So once you form the protoporphyrin ring, you form the heme by adding iron to it. You are going to form the heme by adding iron to it, which is again very crucial because this step is mediated by a very important enzyme called a ferrochelatase. So these are the two key enzymes which I am going to discuss. Both are mitochondrial enzymes. This ferrochelatase is also mitochondrial enzyme. This ALA synthase is also mitochondrial enzyme. That's why I have drawn something like this. So you can see any problems in the ferrochelatase enzyme or any problem in the ALA synthase enzyme is going to definitely result in a sideroblastic anemia. And the classic condition where you get a sideroblastic anemia, first one, you can get, by understanding this you can tell the cause also. So you can tell hereditary enzyme deficiencies. Hereditary deficiency, there are two things are there. One is called your X-linked sideroblastic anemia, hereditary deficiency of ALA synthase, where you have one important disease called X-linked sideroblastic anemia. It's a hereditary deficiency of ALA synthase. And the second one, you have something called Pearson syndrome. This also one form of an ALA synthase deficiency only, but this is a different mitochondrial defect which I'm not going to talk right now. So this is called a Pearson syndrome, but this is a typical mitochondrial defect. And many of the patients, what is the clue is they have sideroblastic anemia. At the same time, they have something called a pancreatic insufficiency. So which means they have pancreatic insufficiency like steatorrhea, diarrhea, chronic diarrhea, abdominal pain, all these things can happen. So the patients might have pancreatic insufficiency, which is a very important feature of a Pearson syndrome. You can remember like P stands for Pearson syndrome for pancreatic insufficiency along with the sideroblastic anemia. And second thing, you can tell other conditions that can cause a ALA synthase, functional ALA synthase deficiency like pyridoxine deficiency, because you know pyridoxine is a cofactor for ALA synthase. So pyridoxine deficiency may cause functional ALA synthase deficiency. Since the cofactor is not available, the enzyme may not be working properly. Because of that, you might end up with a sideroblastic anemia. Number 3, it could be completely idiopathic. We don't know what is the reason for that. Number 4, you have certain types of myelodysplastic syndrome. Especially there is one type of myelodysplastic syndrome called RARS. This is called refractory anemia with ring sideroblasts. In this condition also, this is because of abnormal erythroid precursors. Because of the abnormal erythroid precursors produced in the bone marrow, they can't utilize the iron. Because it's not because of block in the enzyme or something, they can't utilize the iron because they are abnormally produced. That's what we call a myelodysplastic syndrome, where you have something called a RARS. You have characteristic feature of this RARS is presence of ringed sideroblasts within the bone marrow. So you have refractory anemia with ringed sideroblasts as a part of one of the types of myelodysplastic syndrome. And next thing, you have a lot of reversible causes, especially reversible in the sense usually it will be due to some drugs like alcohol. Alcohol can effectively inhibit your ALA synthase as well as dehydratase enzyme. Then you have lead poisoning, you know very well where lead poisoning is going to act. Lead poisoning, classical sites of inhibition is on the ALA dehydratase as well as ferrochelatase. This ferrochelatase and ALA dehydratase, are the classical sites where lead is going to block. We have discussed the reasons for all these things before itself. So then your isoniazid can cause sideroblastic anemia. Then because isoniazid, you know very well, it's going to cause pyridoxine deficiency because it's going to consume pyridoxine for its conversion. So it can result in a pyridoxine deficiency. That is the reason you get a sideroblastic anemia. And other antibiotics like chloramphenicol, then you can get with linezolid, then you can get with copper deficiency, then you can get with some chronic hypothermias. In all these conditions, you might get a sideroblastic anemia. In this, the most important, if you ask me, the X-linked sideroblastic anemia, to an extent this Pearson syndrome, and you have lead poisoning, INH and alcohol. So these are the very important causes that are very, very regularly asked in exams. So sometimes clinically, if you ask me, these patients with sideroblastic anemia may even exhibit a hepatosplenomegaly in view of chronic iron overload. If you are not addressing this cause faster, you might result in intracellular iron overload, which might result in hepatosplenomegaly, and in worst cases, you might result in a hemochromatosis like picture and cirrhosis and hepatocellular cancer also. But these and all are very rare entities. I mean, unnoticing this anemia for a long time, the anemia is going to kill you before all those things are going to kill you. So definitely the patient will present much before that, and we can easily diagnose. So investigations wise, if you ask me what is going to happen, investigations wise, if you ask me the RBC indices, obviously the hemoglobin will be decreased, the hematocrit will be decreased, the RBC count will be decreased, your reticulocyte index, retica also will be decreased, and if you ask me, your MCV will be decreased. But remember, it's highly variable, but MCV generally tends to be decreased because of poor hemoglobin synthesis. As I already told you, it's a microcytic hypochromic picture. So your MCH will be decreased, your MCHC may be decreased, but your red cell distribution width will be increased. I didn't tell you about this thing in the anemia of chronic disease. In anemia of chronic disease, the red cell distribution width tends to be normal. It's a very important thing. So whenever red cell distribution width, if you take, I told you normal red cell distribution width in two things. One is Thal minor and second is anemia of chronic disease. Whenever red cell distribution width is increased, because red cell distribution width is most important only for a microcytic anemia. It's not that important. All these things are not important for a macrocytic or a normocytic anemia. Absolutely not important, because normocytic anemia evaluation itself is through reticulocyte count and other reasons, haptoglobin, urine hemocysteine, and you're going to see a lot of things. But you're not going to do anything to do with red cell distribution count in the microcytic. In macrocytic anemia, again, it's going to be like B12, folate, and drugs, and your red cell distribution width is not going to be that important in a macrocytic or normocytic anemia. Microcytic only, it's very important. So what are the microcytic anemias that have a high red cell distribution width? You have iron deficiency anemia, you have sideroblastic anemia. At the same time, very important, in a Thal major or intermedia. In these conditions also you might have a high red cell distribution width. Again, this is a very, very important thing to understand about the red cell distribution width, but very important in AOCD and Thal minor, it may be completely normal. Especially the most important is the anemia of chronic disease. Okay, here the red cell distribution width may be increased for that matters. So now if you ask about the peripheral smear, the peripheral smear is going to show something called a microcytic hypochromic picture, because the MCV and MCH is automatically decreased. So you are going to see a microcytic hypochromic picture classically. Suppose if the patient is having lead poisoning, you might see other findings also. The patient may have additional findings like basophilic stippling in the peripheral smear, possible. At the same time, patients may show something called a Pappenheimer body in the circulating RBCs. Pappenheimer bodies, which we've already discussed how they are formed. So Pappenheimer bodies in the circulating RBCs. Then if you ask me about the iron indices, definitely your serum iron will be increased, your serum ferritin will be increased, TSAT may be normal or increased, your serum, soluble transferrin receptor will be decreased, and your serum transferrin will be decreased. So because of that, TABC also will be decreased. It is like an iron overload state only. Simple, as simple as that. So all these things are going to happen. So then next step is like when you see a bone marrow. If you ask me, this bone marrow tends to be the gold standard for diagnosis. They ask you best gold standard, always it's the bone marrow. Bone marrow, you are going to see the characteristic thing that is called a ring sideroblast. So when this ringed sideroblast is considered to be specific, if it is more than 15% of erythroblast population. So among all the erythroblast, if you have at least 15% or more is composed of ringed sideroblast, then it tends to be very specific, and you can establish a diagnosis of sideroblastic anemia. So which is again very important. Then what are the other things? Your serum free erythrocyte protoporphyrin is variable, but in general it is increased. For exam, if they ask you, tell it is increased. But apart from that, it is highly variable. Your serum erythrocyte protoporphyrin, it may be normal, because if the ferrochelatase deficiency, then protoporphyrin may be increased. In other conditions like complete ALA synthase deficiency, even if erythrocyte protoporphyrin may be normal or decreased. So you cannot comment on that, it's variable. But in exam, if they ask you, tell it is increase in general. Because again, I told you the only microcytic anemia with a normal serum free erythrocyte protoporphyrin is thalassemia. You have to be very careful about that. Very important point. Then what could be the treatment? Treatment, if you ask me, again, treatment of the cause is very important for sideroblastic anemia. So what is the cause? You address that, because many times it could be reversible and drug induced. So address the cause, and you can give high dose pyridoxine. Typically, especially it works for idiopathic and hereditary cases. If you have hereditary case, or if you don't know the cause, idiopathic case, in that cases this high dose pyridoxine can be working to an extent. So it's been proven therapy. At the same time, you can give supportive transfusion. But remember, the moment you give long standing, if you still don't know the cause and the patient is again going for anemia, there is no other option. You have to make the patient transfusion dependent, but always add iron chelators if the patient is having chronic transfusion, because this patient is already having an iron overload already, because they can't utilize the iron. So give iron chelators and prevent the iron overload from happening, because that itself is going to create a lot of complications. So with this we have not yet done, but it's very important and imperative to know something about the lead poisoning as well, because I think this is the time to discuss on the lead poisoning also, because you will have a strong idea about what's happening. So lead poisoning. So when the lead poisoning will happen? If you ask me the epidemiology of lead poisoning, typically it happens in children 1 to 5 years old. So typically, very commonly, who are affected, who are at risk for developing lead poisoning, is this children with 1 to 5 years of age. And remember, it can happen in utero also. Lead poisoning is possible in utero itself, because lead can cross placenta. Very important point. I mean, they have not asked whether it will have findings in utero or not, but actually speaking, this question has been asked already. It's one of the old questions, I think All India questions in 2010, where they asked whether lead can cross placenta or not. Yes, lead can cross placenta, definitely yes. At the same time, it's a not very common cause. Sideroblastic anemia's most common cause is the drugs and alcohol and all these things, not the lead poisoning. Lead poisoning is a very uncommon cause of sideroblastic anemia. This is not, with the awareness that is increasing in the world, this is not a very common thing to happen. So if you ask me the causes, what causes the lead poisoning? Risk factors for developing lead poisoning is number one is pica. Especially this is a very high risk factor in children. Children is one population where the pica is too much. The craving for the inorganic substances, that's what we call pica, pacophagia. That is too much actually. They can scrape the paints and they will eat pencil leads, all these things they tend to eat, isn't it? So that's typical of pica. So very common in these children, that is the reason. And second thing, in pottery industries, especially those who are working in pottery industry, those who are working in battery, because battery contains a lot of lead, battery, ammunition industry, arms division in armies, so battery ammunition makers, and radiation instruments, radiation tools repair, because they are the ones, again, they are going to involve with a lot of lead. Then even some medicines, actually we have seen, especially certain Siddha medicines I have seen where lead is being mixed, maybe unintentionally, I don't know, but we have isolated some components of lead from certain alternative and natural medicines also. But anyways, fine. So these are some of the causes, but nobody is going to be bothered about the causes in the exam. So if you ask me the pathophysiology, this is what is very crucial to understand. So if you ask me what is the pathophysiology of a lead poisoning, it's quite simple. Number one, it's going to denature enzymes. Lead is going to denature a lot of enzymes. If you ask me what are the enzymes that are denatured, one is they're going to denature enzymes of the heme pathway. They're going to denature a lot of enzymes of heme pathway. And second thing, it's going to denature ribonuclease, another enzyme called ribonuclease, because this is these enzymes are found to be particularly susceptible because these are based on, the cofactors for these enzymes to act are certain divalent cations. So let us see. For example, if you ask me, because lead replaces those divalent cations and they may completely denature the enzyme and make these enzymes completely non-functional. So if you ask me about the heme pathway, two enzymes are classically denatured. One is called the ALA dehydratase, and second one you have, so first is your ALA dehydratase. First is your ALA dehydratase, and second one you have something called a ferrochelatase. Second one is a ferrochelatase. These are the two classic enzymes that are denatured. In this condition, if you ask me, ALA denatase needs zinc as a very important like metal that is associated, and ferrochelatase, iron is very important, then only it can work. These both, if you see, these are divalent cations, and lead can completely replace these divalent cations in that place, and they can completely denature these enzymes. So that is the reason. So in both these enzymes are denatured, that is the reason you get a sideroblastic anemia. Sideroblastic anemia. So they do not only cause sideroblastic anemia, at the same time they can also increase the levels of delta ALA. You know that very well, because I have told you already, you have that pathway, isn't it? So your succinyl-CoA and glycine form delta ALA with the help of ALA synthase, and this delta ALA is going to form PBG with the help of ALA dehydratase. So when lead denatures this ALA dehydratase, you are going to have increased delta ALA, and that is what is going to cause the abdominal pain. At the same time, lead can also cause a lot of neuropsychiatric complications like peripheral neuropathy and psychosis, depression and all, typical like your acute intermittent porphyria. So all these things are very possible. So it might closely mimic your acute intermittent porphyria also. Let me tell you. So delta ALA synthase, increase in the delta ALA. That is the reason for all these complications as well. So once they denature this ribonuclease, so what happens is, once you denature this ribonuclease, you are going to have these ribosomes are not degraded. You are going to have a reduced ribosomal degradation. So once you have a reduced ribosomal degradation, you will result in your RNAs will be persisting within the RBC. RNAs will persist within the RBC, and this is the reason why you result in something called a basophilic stippling. And what lead poisoning causes is something called a coarse basophilic stippling. They are going to cause something called a coarse basophilic stippling. That's what they are going to cause. And similarly, if you ask me about the clinical features, what is going to happen? So clinically, I can divide into two. One is in children, and second one is in the adults. So what happens in children? Typically, they come with abdominal colic, which is also referred to as something called a lead colic. Acute ingestion of lead, sometimes even because lead is radiopaque, isn't it? So if they have taken this lead pellets or lead substance, lead related substances, you can see in the abdomen also. In X-rays also might show these lead components within the abdomen, which I will show you the image in some time. So abdominal colic or lead colic, and will result in chronic constipation also. Constipation in lead poisoning may be due to direct muscular damage, smooth muscle damage by the lead. At the same time, it might cause local autonomic neuropathy also. Because of the toxicity, they can damage the airbags and myenteric plexuses, and because of that also you might result in a chronic constipation. That is also possible in a lead poisoning. So children present with abdominal colic, the other is called as lead colic. Second is they can cause encephalopathy and cerebral edema. Lead encephalopathy and cerebral edema. So why they cause lead encephalopathy and cerebral edema is because lead damages the capillaries and the blood-brain barrier. So once they damage the capillaries and blood-brain barrier, because of fluid leak and congestion in the brain, because of that you might get a cerebral edema and encephalopathy. But early stages, children may not have encephalopathy or a frank cerebral edema. They might just come with the features like poor school performance, your concentration might reduce, and children might come present with your learning disabilities. All these things are common. So that are early features. Frank encephalopathy is generally quite rare, but these are the subtle findings like learning disability, concentration problem, your poor school performance. All these things can happen with lead poisoning. At the same time, you might get with growth retardation, because lead tends to deposit in the epiphysis of the bones. Once they deposit near the epiphysis, they inhibit the growth of the epiphysis, which might, in chronic condition, they might result in growth retardation also. And actually, the lead depositing within the epiphysis, you can see those as lead lines again, which I am going to show in the image in some time. So those are called as lead lines. So in adults, what you're going to see is typically peripheral neuropathy. This is what is classic in adults. Peripheral neuropathy can be any type of peripheral neuropathy. Very commonly, they produce wrist drop or foot drop or both. Very common. This is the commonest, radial nerve or peroneal nerve. This is what they're going to affect very commonly, and they can produce a wrist drop or a foot drop, which is again very important. And next thing, if you ask me, they can produce renal damage in adults. Renal damage is also extremely common in adults. If you ask me about the renal damage, where they produce something called a proximal RTA or a Fanconi syndrome. Remember, Fanconi anemia is completely different from Fanconi syndrome. So they can cause a Fanconi syndrome or a proximal renal tubular acidosis. In fact, not only lead, any heavy metal can cause a proximal renal tubular acidosis. So that is something different. So you can see something called lead lines as a clinical finding in adult. So these are called as otherwise lead lines. Where you see these lead lines is in the teeth. In the teeth you can see this also is referred to as blue lines, are also referred to as something called Burton's lines. Burton's lines, usually it is seen in the, near the gums, especially in teeth which have gone for caries, or the patient is having a pre-existing gingivitis, then only you can see. In normal teeth it's very difficult to see. A patient is having pre-existing gingivitis, because the leak of the lead from the blood, you might see a blue line that is near the gingiva of the teeth. So that is also possible. So both children and adults may show sideroblastic anemia. So sideroblastic anemia is not a feature of child or an adult, both may show sideroblastic anemia. So with this we can see the images of the lead poisoning. So what this X-ray is showing is a child who has taken intake of lead. So you can see a lot of lead pellets here, a lot of this pencil leads or whatever it is. You can see a lot of lead in the abdomen, rectum, in the colon and all. So this, because lead is radiopaque, that is the reason why it is visible. So next thing what you are seeing is the lead lines. You can see a white density here. These are all this white color density. This is what we refer to as lead lines in X-rays, where the lead tends to deposit near the epiphysis. And next thing, if you ask me, this is what we refer to as the blue lines, or simply referred to as Burton's lines or Burton's sign. So these are nothing but the lead lines. Occurs in areas of the gingiva where the patient is having pre-existing gingivitis. In those areas you might get these blue lines or Burton's lines because of the lead toxicity or lead poisoning. If you ask me, but test-wise, if you ask me, none of these things are going to help you to diagnose lead. The best and the gold standard test is you have to see something called whole blood and urinary lead levels. Whole blood and urinary lead, that is going to be the gold standard. This is the gold standard, and this is the best test for diagnosing lead poisoning and lead toxicity. And treatment wise, if you ask me, we are going to do chelation. That's a very important thing. Chelation for leg therapy, it's better done with Succimer, it's called DMSA, or you can do with dimercaprol, or even you can do with the EDTA. That's called ethylene diamine tetraacetic acid. So you can do with any of these things, but we prefer Succimer usually, but you can use anything. So any of these three things you can use. So usually, what is the target for chelation? If they ask you what could be the target for this chelation therapy, your blood level, you have something called blood lead levels, that's called BLL, blood lead levels. So this BLL should be less than 10 micrograms per deciliter. So once your BLL of less than 10 micrograms per deciliter is reached, then continuation of the chelation depends on how much lead has been taken. At the same time, what is the initial lead value, and at the same time whether the patient is continuing to have lead exposure or not. All these things is based on whether to continue the chelation therapy or not. But in general, if the patient is not having any continued exposure, if the initial lead level is average, not very high, then once the blood lead levels is reached to less than 10 micrograms per deciliter, you can stop the chelation and you can monitor the patient with annual blood lead levels. Every year you can do a blood lead level after that, and after stopping the chelation therapy. So this is what we do in general. So these are the treatment for your lead poisoning as well. So we have seen different types of microcytic anemias. The two most important, that is anemia of Cronidis and sideroblastic anemia, with the bonus of we have seen the lead poisoning also in this section. Maybe in the next section, because thalassemia alone is a huge topic, so it needs a lot of discussion, because the most important thing about thalassemia is, which we're going to discuss in the next section, is about you need to understand the beta globin chains in this, because beta globin is one of the earliest genes that are sequenced by the human. So that is the reason why the beta globin gene is very, very important to understand. At the same time, that also gives rise to basic understanding of so much thalassemias and hemoglobinopathies in the future. So see you.